Today I want to discuss the connection, cervical neck and TMD connection. This is not the topic most often talked about, and so this is something that I'm passionate about, and I've been doing cervical neck and TMD the treatment in my practice for a while, and so this is something that I just want to share with you guys and see kind of little eye-opening, and that's what happened to me when I first learned. So this is a little bit about me. So I'm associate faculty at Dawson Academy, and I did my dental school in University of Louisville in Kentucky, and then did a residency in Florida in St. Pete. And I did the 2 year there and got to know Dr. Dawson. And from that, my journey with TMD, orofacial pain, and such a great mentor. He invite us in the house and spend dinner and just asking about all this TMJ questions. And it was just wonderful. And it just he opened the door, so many doors for me, and I forever appreciate him and an opportunity. And from that, so I did a whole at that time it was a curriculum, not the residency. Now Dawson Academy offer even easier path to learn everything is as a mini residency. So I finished everything there, and then I wanted to learn a little bit more about orofacial pain. So Dr. Henry Gremion was the dean at the LSU. So I went there and spent year continuum with them and to learn more about orofacial pain. And that's kind of how I got into the cervical neck, the treatment. So and I practiced with a gentleman named Dr. Hermits in private practice in La Jolla in San Diego. So even though I'm gonna talk about the neck and TMJ today, that's not all patients that I see every day. And being in Southern California, the cosmetic dentistry is a very big, and that's something that I'm very passionate about as well. So these are just some of the cases that I do, and I just want you to share that orofacial pain is not the only one that I do every day. And I love surgery and extraction implants and all that too. So before we start, I just want to recognize some of the names and that influenced my career, and I just want to thank them and opening the doors for me. So I want to start out with the case. This is Elise. I want you to meet Elise here. And this is the patients that actually Elise is my hygienist. And, she actually, we set it up the time and doing comprehensive exam and, just like our, all patients and, routine every 3 to 5 years when they're due an x-rays, and we do complete exam, regardless of they have pain or not. So I know she is hygienist and she has a meticulous, daily, routine, the cleaning routine, and but we still do the same routine exam for everyone. So she has a great hygiene, and I notice a little bit of the recessions and black triangle, but I don't see any plaque, and she has no complaints on the teeth. You look at close, yeah, obviously we could do some BioClear and then some composite. And I noticed the right side and upper right side that has a little bit more gum recessions than the left side. And, she has no sensitivity. Maybe, we could consider, grafting, connective tissue graft to just change the phenotype and then also boosting the keratinoid tissue. And occlusal area, she has some old amalgams and been there for like 30 plus years, and and she has no decay. Now, for us, and we always look at the cervical neck area, especially if there is any signs and anything that would trigger that she would benefit from the cervical neck treatments. And one of the things that she mentioned was, occasionally being a hygienist, I have a neck pain, it's time to time, but it's not a really teeth issue or nothing, anything like that. But this is one of the things you should know, and you and I both should know, as just even doing like one single crown or one surface of the occlusal composite and second molar. And when we look at it, her, the cervical neck C1, atlas is about 2.66 degree off. A lot of patients that has the more recessions and aware, and we understand that occlusions matters with the recession as well. This is one important factor. And we always like to get more diagnostic data to understand the etiology of issue. And especially if you don't know what's going on in the cervical neck, then we're missing big picture, big informations of the whole picture. So I just wanted to, start with this case and then, show you how we treat her, and also to give you some the idea. So we're gonna start out with anatomy of cervical neck junctions and then how that affects the TMJ. And then also understanding how this, why is it important to, we talk about cervical neck, and especially if I want to have a TMJ patient, why does it matter? And we want to look at the occlusions and TMJ cervical neck connections. And then some of the workflow and how to collaborate with the upper cervical chiropractor. So we're going to talk briefly about what upper cervical chiropractor, do. And then we're going to go over the case. Now, so understanding anatomy is very important because one is you want to understand that to also understand that what's, the etiology of the issue, but also explain to the patients, what's going on. And what's very interesting is the C1 and C2, atlas and axis, there's no disc. So that's the area that, if there's a misalignment, and you will see that if that affects to the mandibular area and the maxilla. And one of the things that we see, because we always pay attention to the mandible, where the the TMJ and the mandible and condyle. But if there's a misalignment in atlas and axis, there is actually the skeletal, where maxilla, maxillary teeth, and attached to maxilla, there's a cant. And I'll show you how that happens in here, because now the occipital bone is a part of the bone that composes skull, and there's what's called this structure called occipital condyle. And that's where atlas and it has the landing area, and they exactly sit. So if you look at, this is a dens and then the atlas in here, and if there is any misalignment, your skull, your head has to tilt and compensate in a degree. And there's a lot of structures there in between. And we understand there's a brainstem, there's a blood vessels, a bit, and then there's a nerve. And there's a lot of reverse symptom that we see, when there's a misalignment. So on here, and then, mark it the colors, and that's how they, sitting together. So, and patient usually say, oh, I have a neck pain, but it's not really related to the teeth. But, we may think a little bit differently. Maybe patients not connecting these two dots, or the dentist not connecting the dots. But what we do, and if you make a guard, that also matters with condition of the neck, because you often adjust the bite, and and patient keep coming back and like, I still feel that there, and maybe that's associated with the neck condition too. And then I'll show you some of the cases. Now, this is a CBCT that pretty much all of us are very familiar now. And this is one of the things that we check. And often when we get like implants, do the implants or surgery planning, and we get the CBCT, and this information is already there, and we just don't look at this area. But this is the kind of the axial view and how the C1 and C2 looks. And that's the dents, and we're looking at the coronal view. And this is also one of the key view that I look at to analyze what's going on there. And for me, I'm not trying to diagnose their cervical neck condition. It's more, I'm trying to figure out if this is something that I need to collaborate with a specialist, cervical neck specialist. And so, I can do the little bit more predictable dentistry. For me, one of the things that I use, often is the T-scan. This is a key where I use and before and after the neck adjustments because I often see the difference. And at this point, I didn't even treat the patients, and only thing I did was, we did the thorough detail exam, and then we saw some of the misalignments in neck from the CBCT and work with a cervical specialist, and then we see if there's any bite changes. 100% of the time, and I have treat hundreds of patients with on the cervical neck, and we see before, so when patient presented on my appointment for the first time, we get the T scan, and then after adjustments, and we get another T scan. So here's the example. So on here on the upper and on the top view is that's where the pre-cervical, and this is where they stay on the on their right side. And after adjustments, and their bite is not perfect. They're not, front teeth are not touching, but I'm not looking for perfect bite. I'm looking for changes, but it always changes. And see how much of the right side contact, and mainly on here now it stays more on the middle portions. So it's always change. And this is the key information that I find it because it's my orthotic or my dentistry and occlusions, it stays more stable when the neck is stable. So this is where I'm trying to get the points because we want the stability of the TMJ, cervical neck, and the occlusions. So this is exactly what I'm talking about here. When we do the, dentistry, when we open the eye, the TMJ, and we understand, like we try to get the TMJ in most repeatable and stable position. So my dentistry that I put in the mouth and wants to be there for a long time. And to me, it's the same idea with the upper cervical neck. And some of the cases that I, pay attention to the central relations and the TMJ, and some cases that I have to come back and get the interference again, and had to adjust it again, and that episode, and then that how many times I adjust is greatly reduced after I incorporate the cervical neck treatments. So, in general, the TMD or facial pain, the training, we maybe take one or two class. In my case, in Louisville, and we had one class, over like TMD, and then there now is a recognized specialty as oral pain, and it's 2020. And like you guys, and being learning, and now the webinar here, we have different the continuing education, and that's kind of how we learn and recognize the informations. So based on the training, and everyone look at and analyze things different. I mean, like this pictures, and they just describe what they see. And in our oral facial pain and TMD in the field, you know, um, if you have a heavy occlusions of training, and then we try to solve the issue with the bite adjustments, or if you're oral facial pain or a neurologist, and they look at the neurology and do the gabapentin or medications, we look at things a little bit different. So as much as we know different areas, and what are the things that we can do more predictably to the patients, and we can help them better. So let's say, tomorrow morning you have a new patient coming in with this, the conditions, and now everyone will, look at things a little bit different based on what their comfort level, what of the, the treatment they provide, or if they have, referral like specialists who have a good relationship with. I mean, obviously this patient has a lot of things going on. I mean, there's a crowding, there's a scallop tongue, there's a recessions, and transfers, narrow transfers, the arch, and I mean wear and inflammations, and you name it. So, in the situations that, we address, okay, well, let's look at the airway and that's a big, and now we do, right? So airway, breathing, there's a large tori, narrow arch, and maxilla, and tongue posture. Maybe we need to work with the myofunctional therapist. Maybe we do the transverse expansion with maybe MARPE, or we do surgically facilitated ortho and trying to, expand arch. But how about, the condition of the neck? And is this something that we often talk about? Not really, right? But to me, this is especially important when you're talking about SFOT and then, all that, the approach. And I was talking to one of a very, well-known and, orthodontist who does MARPE a lot. And she often see the misalignments on the neck, and also, when they do MARPE, sometimes those cut and, it's not exactly happen in the, middle. Sometimes, the facial structures can change a little bit while the expansion, because, which the suture is gonna break. So especially to me that I'm interested in and see long-term studies, and if the atlas and axis and the cervical neck is a stable, and if the SFOT and also MARPE will look even better than outcome. So yeah, like if patient shows up and has some of the degree off from the C1, C2, C3, and this definitely affects to your treatment outcome. So right now, I was looking up the kind of the statistic. 10% of Americans have some annually they visit the chiropractors, and 20% of them is actually specific for the neck pain. That's a significant amount of the patients, and this is one of the things that I recommend to all of us that during the our health history in the new patients, or when we update the health history, we always want to include, and if you see a chiropractor and in the routinely, or what reasons, and that may affects to the what you do every day. And these are the typical symptoms. So like, some of them overlying, I mean, headache, ear pain, temple pain, those are the typical, we say, the TMJ pain. And the neck pain, tenderness of the jaw, tenderness of the muscle in the head, face, and neck. I mean, very similar, because it's a reverse symptom when there's misalignment. It's a pinching nerve, and it's, drives the trigeminal nerve, and, and you usually get those reverse symptom. So a little bit about the orofacial pain. So we need to discuss that. We usually this kind of divide to two categories. One is we call the odontogenic pain. That's something that you and I are super good at, and we always good at diagnosis. There's cavity or recessions and whatnot. That's the world that we live in. And then there are other non-odontogenic pain that's showing up as in the face as a pain, and sometimes in masking the pain, so it's kind of hard to differentiate which one's coming from. And my world, and something that I'm able to predictably treat is the TMD and the cranial cervical, the pain. So those are the two. And for me is I don't like to try something as more experimental treatments and hoping that patient gets better. And instead of doing that, I want to do something predictable that I'm able to help them, because these patients are coming in from long history of many doctors visit. I mean, neurologists and dentists, and they usually have multiple some different type of guards. And so it's my best interest to help them in the most predictable way. And so now we know, we discuss, and this is something that we are super good at, and tell, like with the decay and infections. And non-odontogenic pain is something that you like to collaborate with the specialists, like neurologists and and different ENT, because it's layers of issue usually, and there's high sympathetic, the response and whatnot, and those are the things that you cannot treat everything. So I urge to find the mind like specialists in town and, collaborate. So the good thing, though, out of non-odontogenic pain, the TMD is a major cause of the non-dental related facial pain. And, we are looking at about 12 million the people, and experiencing some TMD, and those are the patients that we can effectively the help. And the other non-odontogenic pain is the cervical spine, and that's something that we are talking about today. Now, we start now, like, how we start everything in terms of, like, picking out the patients who needs help, the cervical, help. Is we start with the complete exam, and now we look at airway occlusions, the gingiva, we look at the biotype, and the teeth, individual tooth, if there's a caries or a cavity or infections, and then also the TMJ conditions, if there is any, anterior displacements or the range of motion is limited in the maxilla and mandible, and then also the cervical neck. So we do the complete photo series, and and this is all our new patients and existing patients get the series, and this is especially great because I find it best way to communicate with the patient is photo. So we routinely take these photos, and we have 20 by 20 CBCT, and now we have most of us have access to the CBCT, whether you use a center, imaging center, or you have it in your office. But one of the things that if you ever consider getting CBCT is you need to have a large field of view, at least 15 by 15. For me, I know, like, some of them is like stitching image, and you do the 2 scan and they stitch and then make it bigger, but I'm trying to do less, the image. And also my population patients are, let's say 60s, 70s, and 80s, and it's hard to hold still. So I want to do like minimum fast and get, both of, the condyles and in one plane instead of like separate. And because it's hard to, analyze in the view. And then we merge the data. We look at the condyle, we look at the, occlusal plane, gingival zenith, interpupillary line, and, the condyle, and just to try to see if there's any misalignments on, on different view. So with that, and if there is any suspicious of a misalignment and something doesn't look right, then we work with upper cervical chiropractor. Now, there's different school of thoughts on upper cervical chiropractor, and see, I recommend you research and also find the cervical specialist who, I would say, also the personality match. And that's important because the patients are coming in to see you and they like you, and they like to meet someone that, similar personality. So, there are 3 different, specialists that I work with in the different training, and Nuka, Atlas, Orthogonal, and Blair. And after they adjusted, the neck, and, they refer back the patients to me, and usually I see 24-hour window because I want to see them before and the adjustment doesn't change, and then they make it stable. And then usually they hold the patients for 2 months or so and then refer back. At that point, then I evaluate, and and the occlusions, and get central relations and diagnostic cast, and decide if I need to do any additive or subtractive equilibrations, or in case that we need to stabilize the joint before we do anything, and make it orthotic. And after that is that we do the maintenance, like we do occlusions, and if we do make it orthotic, or sometimes we work with a myofunctional therapist or physical therapist. And that's the kind of the cycle, like the cleaning appointments that we maintain in the same way. So yeah, pretty much I described this way. So we do the complete exam, phase 1. If there's any, broken tooth and there's infection, obviously we want to address that first, and then refer to upper cervical chiropractor. and schedule with us and within 24-hour final adjustment. This is important to get the right data. And then we get the diagnostic cast and face value, CR record, and then we do occlusal TMJ stability management, with whether that's orthotic or subtractive or additive equilibrations. And then we work with other specialists for the maintenance. So before we go over the cases, I want to look at if there's any questions. Let's see. Q&A. Is there any relation between forward neck postures and DDWR? Yeah, I mean, forward, let me go back to the slide. So yeah, forward head postures, and there's something that I work with the myofunctional therapist too, and this the cervical neck patients and often associate with the sleep, and we work with the sleep doctor, and in our case, it used to San Diego sleep doctors, and we want to rule out why they have a forward head postures, and so we often work with them and get a sleep test, and now our case is more the home sleep test, and then with that, and we try to have the baseline, and then sometimes we use photona laser, and we work with the sleep doctors and they do CPAP, and we do some of the night lays and to help out with the tissue tone as well. So that's kind of how we approach. Okay, so let's go over this John case. So John had orthodontist. This is the orthodontist referred to me, and he showed up in ortho office and asking, I want to get braces and or Invisalign, but I wear guard and I have like the TMJ pain, so I don't know what to do. So then orthodontist like, well, you need to see Dr. Kim first, and you need to stabilize that first before we start the ortho. So his medical history is pretty normal, no history of surgery, just multivitamin. He's in 20s and healthy guy. And he had occasional muscle pain. He's in left jaw since 2016, and then he had occlusal guard made in Korea in 2018. And he had a frequent left side neck and jaw pain. So jaw and neck, all the left side. And feeling his jaw is shifting his left side and teeth are becoming more misaligned. So he feels like a muscle is pulling on his left side. And we go through 0 to 3 pain scales and the palpation of the muscle, and we see the left side he's definitely responding on the left side than the right side. He has normal range of motions, max opening 48, and protrusions and laterals. And he didn't have any clicking and popping. And sometimes he has left side TMJ area, temple and the TMJ area, the pain. And we noticed that there's some of the midline is off by 2 millimeters or so. And this year, the loading test, and he was normal. Now we on this, the series of photo, and we look at if there's any asymmetry. Now, obviously, his facial midline, and we look at the divide and left and right side, and we see the occlusal plane, and then inside the plane, and then his chin point is a little bit deviated. And interpupillary line, and when you look at it, his left side is a little down than the right side. Now, we also look at occlusal plane, and you see the gingival zenith and occlusal planes, and is canted. And then occlusal plane in the lower on the mandible is canted the other directions. And I find it interesting that patient who has, like, let's say, any micro trauma over time, and they have an issue with the growth center of the condyle, if there's a different size of the ramus, and we see that actually gingival zenith and occlusal planes is following the same direction. In his case, this is opposite, right? The left side is higher, the right side his right side is higher in the mandible. And usually those cases acquire, the trauma, meaning that one point he was lined better, and whether, he had a car accident or some kind of the, impact, or the dentistry was done and was not favored to his TMJ positions, then usually I see the patterns of that in the opposite directions. And then we also look at that if there's any interocclusal space difference. And of course, we, look at the sinus, and if there's any, inflammation of the sinus, if there's any, narrow, deviate septum or narrow inferior, the concha or the middle concha and the space. And we look at the C1. I mean, this is important information. So I, make a cross from the dents and see the midline of the tooth. If there's any rotations of the mandible or maxilla, in this case, in the maxilla, and see how much is off from the dents. It's about 4.6 millimeter off from the, midline. And, see how much is the, the rotation going on the cervical neck. So again, this, the millimeter and 1.7 millimeters off, and then one side is higher than the other side. But this information, I'm not trying to be okay, like 1.5 off. It's more like we recognize that there is this discrepancy, and this is enough information for me to refer to the cervical specialist and then, working at. We look at the condyle and then, also the space in the glenoid fossa, and also the mandible positions. And if the left side, where the mandible positions and relative to left and right side, now, and also responding to the occlusal plane. And these are the cases that when you adjust on the left side, and you do the crown and then you adjust it, and then often expected because the, how the mandible is a favor, the position of the skeletal bone, and usually you pick up the interference there. And this is the key information for me. So when I make orthotic and, I, factor that in on that, the adjustments when we do that. Now, this is he brought in 2018, he had a guard, and I saw, there is only catching in the front area, but obviously he has all the marks that he, had to wear. So this is something, the key information is that like something has changed, whether the TMJ, whether the neck, and, so I just, took a photo after, getting the bite there. And he goes, and at that time I was working with the Atlas orthogonal chiropractor. And what they do, all these doctors then don't do the manipulation of the neck. And that's not something that I advocate. And I personally not the favor of doing the manipulations. These are all like very subtle adjustments. And then that's what they do here. So he went there, had an exam, and, there's specific x-rays, and then had adjustments. And this is after adjustment at this point, and I didn't do any adjustment on the guard, and patient just show up with, after adjustment and with the guard, and I just, check the bite. And obviously you see a big difference on here. So this is a 24-hour after adjustment. I asked Johnny that how, his experience.
All right. So Johnny's here. He's after 24-hour adjustments. Johnny, can you tell us the experience with your Atlas adjustment?
So I went to the Atlas, Dr. Van Doren. Then he had this machine. First he just checked whether or not my posture was all correct. He took a few X-rays, and then measured my Atlas. Then he used that equipment, some Atlas equipment, and then it wasn't painful at all. But after a few adjustments and after a few usage of the equipment, my neck and shoulders were like completely especially my neck was more relaxed, and then it was completely painless, and it felt nice because I was driving back and it felt my because when I drive my whole body's usually very tense because I'm very stressed when I'm driving, but I thought I was very relaxed after I was driving.
Yeah, and then I asked him if he has noticed any changes in the bite.
So after I got the treatment, I went back home. It was around 7 p.m. ish. So good enough time for, I guess, acclimation. Then I went to bed around 11, and then I wore my night guard. Then I realized that unlike last time, so the teeth will like go try to be balanced toward the night guard, but they'll push towards the left. So I could feel that because my tongue was scraped towards the left. But this time, the right canine teeth was touching way more on the right. And it wasn't painful at all because when I was sleeping and when I woke up, the left wasn't painful at all, the left side of the jaw.
So your jaw feels better with the left side after
Yeah,
adjustment.
yeah. Because my every time in the morning, so I realized that my tongue will always scrape on the left because I think my left is always pushing so much on the left night guard. But in the morning today, none of that happened.
Thank you, Johnny.
So keep in mind that I didn't do any adjustment on the teeth or a guard or anything like that. But what I find that very helpful with the cervical neck treatment in a case like this is actually finding a balance. And that's something that I cannot just do it by myself. And that's where it's coming from the neck area. So like he described it, it was left side of pain. Now he's touching more on the right side because that's where the misalignments was driving, certain, the pressure. And, we every time that a patient comes back and, they describe the exact same thing because, and now we know like when there's a discrepancy and we are expecting the more, contact and then, the other side after adjustment. So in Johnny case, and he did, the adjustment, and then, and then he came back, and then we look at the splint, and I really didn't need to do the adjustment, so we didn't do that, and we did the record taking appointments, and then his bite and everything was fine, and I didn't really need to do anything. So we monitor him another 2 months to make sure that his pain is not coming back, and refer back to orthodontist. And he actually, this case was actually about two years ago or so. So he's already finished and everything's done, and ortho is done, and he has no TMJ pain or left side the jaw pain anymore. So often we use a laser, the patients, that's something that I just want to share with you guys. And we have a photona lasers that we can provide a photobiomodulations. And often I find it very helpful to the patient who has any facial pain. And how it works is that actually it stimulates the cellular level in the mitochondria and then release ATP, and so it just improves the tissue function and just to reduce inflammation. So this is, if you have it, machines, or if you have access, this is also very helpful to use. So let's meet Elise again. My hygienist, she went to see Blair type of chiropractor. And this was before. I mean, she had about 2.6 degree off, and now we basically, it's not a perfectly balanced, but we see that, the left side, her right side is more down after adjustments. And most importantly, she feels better with her neck. And so we see on also the degree about a 1 degree difference on, before and after. So these are the things that, like, simple imaging, and, if you have access to the CBCT, and this is key information, so you should know as a part of the complete exam. And TMD is very confusing. I mean, it's very difficult. I mean, it's time consuming, and you have to sit down with the patients, and you need to understand that where they're coming from. And often they get like Botox and different therapy, and they have multiple guard, but it comes down to like how much you want to help them and how much and you feel more comfortable to helping them out. So I would suggest, take a baby step. And this is my son. And, like, you need to start somewhere, right? So you cannot treat everything at once, but, just you want to, broad your, scope. And so I recommend, if this is something that you want to get involved more, and maybe try to find upper cervical chiropractor in town, and have a lunch with them and just see what they do, and what kind of TMJ patient they have. Maybe they will refer the patients to you, and this is a good networking as well for your practice. And this is, one of the things that I learned from Dr. Hermitz and always kind of resonate in my head. And, when you first realize and you're unconsciously incompetent, you don't even know what you don't know, right? And then you start learning and they're like, oh, that cervical neck thing, I recognize it, but I don't know how to treat it. And then you spend more time and, learn, and now consciously competent, and like you try to recognize that how to help them, and eventually you become a master and unconsciously competent, and we are all like trying to get there, right? And just to help our patients. We just need to listen, because they always comes with many complaints and very complex problems. So this is the one important our attitude towards the patients, and that's sometimes they just want to meet doctor who is willing to listen their complaints. And this is one of my favorite book, and it takes time. I mean, you need to put 10,000 hours to become a master, and so this is not going to come easy, but there's so many resources and different the contents in the Dawson Academy, and so I recommend you reach out to me, or other faculties, and and to just try to get better every day, and hoping that you become one day unconsciously just competent. So there are some of the reference, and if you like to know more about the cervical neck, and we have a live stream in 3 hours in coming couple weeks. Yeah, so we're gonna discuss in the details, and how we dissect the information.